Distinguished ladies and gentlemen, Your Excellency, I would like now to invite us to the second session. And this session will be moderated by Dr. Simeon Nanama. Dr. Simeon Nanama is the Regional Nutrition Advisor for the UNICEF Office for West and Central Africa. He has worked prior to with the UNICEF in Nigeria, Madagascar, Democratic Republic of Congo, and Chad. Mr. Dr. Nanama, if you are connected, please kindly take the floor now. And I kindly request you to keep to the time because we have many sessions to come. Please kindly take the floor and keep to the time. Over to you, Dr. Nanama.
Dr. Sun, please. Dr. Nanama is late to join. He's just having some connection troubles, and he's in contact with us. So he's trying to join in the next few minutes. Maybe if you could just probably just give us 2-3 minutes, or even though we can probably start introducing some of the speakers in his place as you prefer.
Okay, so let us give him 2 minutes or 3 to join us. And in the meantime, can we have the video? Is that ready? Because I know there is a very nice video on the issues at hand. Can we have the video? I think we continue to have some challenges. So, Simon, do we have someone who can introduce the speakers for the second session? Christiani? Christiani? Is Mr. Dr. Nanama in?
Yes, Dr. Sun, please, I'm just on the phone with him. Just 1 moment, I'll go back to you.
Do we have someone who can moderate that session?
I can probably step in while we wait for Dr. Simeon to connect and introduce our first speaker so that we don't delay the webinar.
That would be great. That would be great, Christina.
Okay.
Christiani, so you have the floor to introduce the speakers for the second session while we are waiting for Dr. Simeon. You have the floor.
Okay. So good morning, everyone. Very nice to see all these almost 300 participants online. We wish you all very nice conference. And I'm very happy. I will just step in for a few minutes as Dr. Simeon Nanama, the Regional Nutritional Officer from UNICEF, will join us. So my name is Cristiane Buani. I'm the head of operations unit in the Regional Center of Excellence, SUR. That is the co-organizer of this conference. So very nice to see you all. So the session 2 is an overview of the state of micronutrient deficiency in Africa with a focus in anemia. The idea of this session is to really set the scene for the sessions that we'll have later, and to really provide you a comprehensive overview of the situation in the continent. And we are very glad to announce that in this session, we count on the presence. We will start with an overview of the state of micronutrient deficiency in Africa that will be presented by Dr. Adelaide Onyango, who is a nutritional advisor at the Regional Office for Africa in the World Health Organization. She will be followed by a more focused presentation of the prevalence of anemia deficiency in West Africa and what is the current state, that will be presented by Dr. Keita. Dr. Keita is the head of nutrition and West Africa Health Organization and one of our key partners to organize this meeting. And our third speaker will be also probably very well known of all of you, Dr. Namakulo Kovic, who is the president of African Nutrition Society, and also the research coordinator on the program Agriculture, Nutrition and Health from IFPRI. So good morning also, Dr. Kovic, thanks for joining us and for bringing you some ideas on why we are struggling so much to reduce anemia. We will have our representative from the Micronutrient Forum, Dr. Saskia Ozandar, who is the executive director of the Micronutrient Forum. So this is our panelist for session 2. And without any more delay, I would like to pass the floor to Dr. Onyango, who will introduce our session in this panel. Thank you very much. And Dr. Onyango, the floor is yours.
Thank you very much, Cristiane. It's a pleasure to be here today. And I think you're supposed to be projecting a presentation that I shared. And just to give you a bit of an update, colleagues, on I was the regional advisor for nutrition until earlier this year, when my responsibilities changed to now I'm directing the PRASTA at the African Regional Office of WHO that is responsible for healthier populations, and that includes nutrition and food safety. So I'm still very much part of the nutrition community, but now looking very broadly at other determinants of health, and where in fact nutrition does have a lot of connections with the environment, the social determinants of health, the other risk factors that lead to poor health outcomes. So as we wait for that video to come up, the presentation to come up, I can also tell you that when we were preparing at WHO, selecting the global nutrition indicators that were then presented and approved by the World Health Assembly, that we now use as the indicators to check on our nutrition agenda globally, the 6 indicators. One of the criteria that guided our selection was the availability of data so that we were able to track progress on the indicators. And unfortunately, most for the nutrition indicators, micronutrient indicators, there is very little data. So only anemia got into that list of the indicators that make the 6 that we are using to track progress on the global nutrition situation. And of course, that also means that in other areas where we needed to have been working, for example, in vitamin A, iodine deficiencies, we were unable to really put this at the center of the tracking. So that's why it still remains a challenge for us. Even today, we lack population representative data, real-time data to help us estimate the true burden of micronutrient deficiencies and to identify and localize who is affected by these. Nevertheless, I think we do have from time to time the rare nutritional survey, micronutrient survey at national level that gives us an indication of what the status is. Otherwise, much of the time, and as this consultation does, is to focus on where we can get some data, and that is on anemia. So if we go to the next, this is an overview of the international situation, the global situation, with data that were pulled together and which gives a very, very broad overview of the situation of micronutrient deficiencies relative to GDP of the different countries. And as we can see here, it is more, micronutrient deficiencies are more severe in low-income countries. And we see from this slide that it is really the African countries are all grouping in the top right corner of the slide. That means that most of our countries, which are low-income countries, also have very high hidden hunger indices, as we can see from this graph. Let's go on to the next one, because we're going to have a very, very brief overview because we don't have much information. So it's really going to be very, very broad. This one gives us the map of the vitamin A deficiency among children 6 to 59 months. And this, as you can see, the information dates back to 2013. And the situation in Africa, I don't think has changed very much, because if we look at the situation that has been described in the SOFI and which has been cited by speakers in the opening session, we know that hunger has increased and hidden hunger even more, because the cost of nutritious foods is getting much higher than most of the population can afford. So if we have an increase in hunger overall, there is likely an even greater increase in the hidden hunger. And this is the map that we can see. The African continent stands out with very high prevalences of vitamin A deficiencies. Next. In this slide, we have from the international, the global nutrition, global iodine network, some data that show us, again, it's a pulling together of data from different years, and to give us a rough picture of where the situation of iodine deficiency is still very serious. And we can see in parts for the African continent, either no data or where there is data, many countries do have what seems to be adequate. And this is based on school-age children, because it's the most accessible information on overall intake. We're going a bit faster than my speaking, but that's fine. I understand there's some pressure on time. So this tells us, however, that we lack data, because these are all, many times they're based on even subnational data. So the dearth of data in tracking micronutrient status is really a challenge that we must be very aware of as we look at how to address those situations next. So on the next map, we're going to see, we have, next please. We have the situation of anemia in women and children. On the right, we have the prevalence of anemia among children 6 to 59 months of age. These are estimates for 2019. As we can see, in sub-Saharan Africa, the deficiencies are quite high. Actually, it's over 60% in comparison to 40% globally. And so as this is a reminder again that we do have a huge challenge in terms of this. It does not distinguish what is iron deficiency. This is based on hemoglobin. And then on the right, sorry, on the left, we have the situation for all women of reproductive age between 15 and 49 years. And we can see that the picture is especially serious for West and Central Africa. If we go to the next graph, it shows us the situation of anemia among women of pregnant women versus non-pregnant women. And it doesn't change very much. Of course, the situation is more serious among pregnant women, and it's still the same sub-regions, West and Central Africa, that are affected, more affected than the rest of the continent. But we are still in the ranges of more than 30% of anemia among women of reproductive age. Next. So this is, I find this slide extremely interesting and very important as we think about what we need to do in order to address the micronutrients status, rather the deficiencies that we're still really grappling with. And that, again, like the map that we saw at the beginning, here we have the situation where micronutrient deficiencies are more prevalent in countries with poor dietary diversity. And again, we can see on this map, most of our African countries are to the top right of the graph, where it shows they have the share of energy from cereals, roots and tubers is very high, more than 50%. And that's also the higher index of hidden hunger. So I think this is an important message to take forward as we think about fortification, because we are also dealing with a situation where the cereals, roots, and tubers are now being transformed into processed carbohydrates. So as we think about fortification, aside from biofortification, where we're going to be looking to actually enrich cereals, roots, and tubers so that which are eaten in their non or minimally processed state, when we move out, when we think about where the energy is coming from, and we consider how much of this energy is now, because of the changing consumption patterns, is coming from processed foods and sometimes ultra-processed cereals, then we should be aware that fortification needs to be to look very much at that holistic look that we need to be taking of the diet, a diet that is wholesome and that is really paying attention to the richer components, what makes for a nutritious and healthful diet. So I think this is a slide that I would say sets an important, sends an important message as we go forward on where we need to pay attention in the presence of the double burden of malnutrition, and which, as has been mentioned, we are looking to address all forms of malnutrition. And the COVID pandemic just brings home to us the fact that we really do need to pay attention to all the food components that are driving obesity and diseases such as diabetes, etc., because those are going to undermine all the efforts that we make to enrich, to fortify foods. So with those few words, I would I say this is all from me for the present, and looking forward to also listening to learning from all the others that are going to speak after me. Thank you very much, moderator. Back to you.
Thank you, Dr. Onyango, for your very comprehensive presentation. I would just like to bring Dr. Nanama. He is here with us now. We solved the small technical issue. So, Dr. Nanama, I'm handing over to you for the moderation of the session. Good morning.
Good morning, Christiane, and good morning, everyone. Please accept my apology for the challenges that I had joining this meeting. I hope you can hear me well.
Yes, we can hear you.
Yes, we can hear you.
Okay. Really a pleasure to be joining this meeting. We've heard from the first panelist, Dr. Onyango, who gave us an overview of the magnitude of anemia in the world, but specifically in Africa, where a number of key lessons have been highlighted. The fact that sub-Saharan Africa is highly affected, children and women are affected, and the link between iron deficiency, anemia, and dietary diversity, those have significant implication for the rest of the discussion. Now, in the interest of time, let's now move to the next panelist, which, if I'm getting it right, is Dr. Namudu Keita. Dr. Namudu is a specialist in public health, working at the West African Health Organization, where he is in charge of nutrition. And since 2008, he has been coordinating programs on primary health care and health system strengthening at the West African Health Organization, and also coordinating the implementation of the organization strategic plan for nutrition for the West Africa region. He is a medical doctor specialized in public health and social aspect of related to health. Dr. Namudu, welcome. You have the floor for your presentation.
Merci bien, monsieur le modérateur, monsieur Siméon Nanama. Et avant tout, je voudrais rendre hommage aux SER-Femmes pour avoir associé l'Organisation ouest-africaine de la santé à cette consultation régionale de haut niveau sur l'enrichissement alimentaire en Afrique en général et en Afrique de l'Ouest en particulier. Et l'OAS est très heureuse donc de prendre part en tant que co-organisatrice de cet événement. Je voudrais donc ici, en tout cas, vous transmettre les salutations chaleureuses du directeur général de l'Organisation ouest-africaine de la santé, le professeur Stanley Okolo, empêché pour des raisons de mission, et aussi mon directeur de département, le docteur Kofi Boussia, également absent. Nous allons donc vous présenter très brièvement la prévalence des déficiences de l'anémie en Afrique de l'Ouest. Où en sommes-nous? Je ne dirais pas grand-chose dans la mesure où l'OMS, qui vient juste de prendre la parole, indique en général les questions de disponibilité d'informations sur l'anémie. Et ceci est un grand défi au niveau continental. Donc, cette présentation n'est pas pour faire l'étalage de toutes les causes et facteurs sous-jacents de l'anémie, mais c'est plutôt montrer quelques tendances régionales et finir par dire ce qu'il faut comme solution au niveau régional et au niveau national. Nous savons tous que plus de 50% de l'anémie chez les femmes au monde entier est liée donc à l'anémie, à la déficience en fer, donc à la déficience en fer, et que cette prévalence varie selon le milieu, qu'il soit milieu rural ou urbain, et aussi l'âge de la femme. Nous savons la femme en âge de procréer, l'adolescente ainsi que le jeune enfant ne sont pas concernés comme le reste de la population. Il en est de même du niveau d'éducation qui influence énormément sur, comme facteur qui peut influencer donc ces questions d'anémie. Et nous savons tous également aussi les conséquences liées à l'anémie dans notre population. C'est la fatigue, donc le problème de productivité, le problème lié également à tout ce qui est les conséquences sur la naissance, hein, les petits poids de naissance, etc., sont donc tous des conséquences qui peuvent donc rendre nos populations improductives. Et nous voyons également cette prévalence au niveau mondial où nous voyons les femmes enceintes et les femmes non enceintes sont les plus concernées, les femmes enceintes représentant 42% au niveau mondial. Et en Afrique, au sud du Sahara, qui prend le plus gros fardeau de ce fléau, est concerné à plus de 57% des femmes enceintes et 48% des femmes non enceintes. Et également, nous voyons qu'au continent africain, l'Afrique centrale et l'Afrique de l'Ouest prennent le plus grand fardeau de ce fléau également. Nous sommes les deux régions cumulent 47% de l'anémie chez les femmes en âge de procréer. Bien évidemment, au niveau mondial, nous avons les cibles qui sont définies pour la nutrition. Je ne vais pas vous les dicter, vous les voyez. Et nous sommes ici, je vais mettre un accent sur la cible qui est de réduire de 50% l'anémie chez la femme en âge de procréer et réduire également 30% la naissance avec le faible poids de naissance, entre autres. Donc, ce sont donc des cibles qui sont définies au niveau mondial avec un consensus général et les pays ainsi que les régions doivent conjuguer les efforts pour essayer d'atteindre ces cibles à l'horizon 2025. Si nous voyons ces cibles, nous constatons que la mise en œuvre au niveau de sous-régions est très variable d'un pays à un autre. Quand nous voyons par exemple la cible de la diminution du faible poids de naissance ou du retard de croissance, nous voyons que le nombre de pays, on n'a que 2 pays qui sont vraiment en chemin pour pouvoir l'atteindre et que des progrès qui ne sont pas du tout enregistrés au niveau de 4 autres pays. Nous voyons par exemple pour ce qui concerne l'anémie en Afrique centrale et en Afrique de l'Ouest, sa réduction de 50%, il n'y a que 8 pays, quelques 8 pays qui connaissent quelques progrès qu'on peut noter, alors que 8 autres pays ne connaissent pas de progrès. Donc, vous voyez, dans ce contexte d'absence aussi de données, comme ça a été souligné tantôt, nous manquons d'informations et ça fait que c'est difficile de faire le point au niveau sous-régional. Nous devons donc encourager à ce qu'il y ait vraiment beaucoup plus d'études et beaucoup plus même de données collectées au niveau prestation, c'est-à-dire dans la routine, afin de pouvoir renseigner et avoir l'évidence pour pouvoir prendre des décisions. Quelques autres informations sur la tendance. Nous voyons qu'au cours des 15 dernières années, quelques pays ont fait des progrès en matière de lutte contre l'anémie chez la femme en âge de procréer. Il s'agit ici, par exemple, si vous regardez le graphique à gauche, du Libéria et la Mauritanie qu'on peut citer ici. Donc, mais il y a au moins 8 pays qui, quand même, ici, on remarque quelques progrès réalisés. Ça, c'est jusqu'en 2016. Par contre, à gauche, à droite, nous voyons que certains pays n'ont pratiquement pas enregistré de projet de progrès. Et on peut citer ici le cas du Cap-Vert, la Guinée-Bissau et la Sierra Leone. Ici également, nous voyons chez la femme enceinte, la même tendance pratiquement est observée. Nous voyons des progrès réalisés par quelques pays à gauche et pratiquement une stabilisation au niveau de certains d'autres pays à droite. Et également, cette carte a été plus ou moins présentée tout à l'heure par l'OMS. Nous voyons donc que la prévalence de l'anémie chez la femme en âge de procréer en Afrique de l'Ouest en 2019 se situe à près de 52% et que c'est vraiment les deux sous-régions, comme je l'ai dit tantôt, qui se voient ici au niveau du graphique à gauche. Par contre, à droite, concernant les enfants donc de 5 à 69 mois, nous voyons que c'est pratiquement toute l'Afrique au sud du Sahara qui est concernée. Toute l'Afrique au sud du Sahara est concernée par ce problème d'anémie chez les jeunes enfants, ce qui nous interpelle à plus d'un titre. En revenant encore toujours à la prévalence de l'anémie dans les deux sous-régions, chez les femmes enceintes, nous voyons que la tendance de l'anémie montre que la réduction est trop lente. Par exemple, pour pouvoir arriver au seuil de 40% qui est fixé par l'OMS, afin qu'on puisse considérer qu'il s'agit bien d'un problème de santé publique. Donc, de 2000 à 2019, vous pouvez remarquer la tendance vraiment très lente de la baisse du taux d'anémie chez les femmes en âge de procréer. Et parmi les femmes en âge de procréer, la courbe de droite montre que les adolescentes sont encore plus touchées comparées aux femmes adultes. Pour ce qui concerne une projection, nous voyons ici que la prévalence de l'anémie chez les femmes en âge de procréer a diminué que de 6 points au cours des 20 dernières années, passant de 55% en 2000 à 49% en 2019. Mais la prévalence actuelle, comme vous pouvez le constater, est très loin de l'objectif de 25% de l'Assemblée mondiale de la santé avec un objectif à l'horizon de 2025. Donc, ça, c'est la courbe de gauche qui le montre. Et si nous nous projetons encore plus loin, nous voyons que la lenteur de cette tendance-là montre que vraiment, il faut encore plus de 60 ans afin qu'on puisse atteindre cet objectif de 25%. Ce qui nous interroge, si nous allons vraiment attendre encore 60 ans avant d'arriver à cet objectif. Donc, vraiment, c'est comme si nous sommes vraiment compte rebours pour que nous puissions accélérer la mise en œuvre de nos programmes prioritaires en matière de lutte contre les carences en micronutriments. Là également, cette diapositive nous montre que la réduction de la prévalence de l'anémie chez les enfants de moins de 5 ans est trop lente également, à l'image de la femme en âge de procréer. Et dans le même temps, cette courbe montre que le nombre absolu d'enfants touchés augmente. Et bien évidemment, certainement, ceci peut être lié à l'accroissement rapide de la population. Ce qui veut dire donc que nous devons aussi agir sur cette question. Alors, pour tout ceci, l'Organisation ouest-africaine de la santé intervient en collaboration avec les pays et des partenaires au niveau régional pour essayer de mettre en œuvre des programmes prioritaires, dont ici le programme qui concerne les maladies non transmissibles, y compris donc les questions de nutrition. Et que les autres programmes sont également connexes à ceci, pour ce qui concerne la santé de la mère et du nouveau-né, l'amélioration de la qualité des soins et la création des centres d'excellence, ainsi que les questions d'accès aux médicaments et aux vaccins, et l'information sanitaire qui est cruciale pour pouvoir savoir où en sommes-nous et comment nous pouvons bâtir nos priorités. Nous avons un plan stratégique en cours actuellement de 2017 à 2025 et qui a pour but de contribuer à la création d'un environnement favorable pour améliorer la sécurité alimentaire et nutritionnelle, avec 4 objectifs intermédiaires qui touchent la gouvernance et la coordination, la gestion des connaissances, la capacité de régulation et de mise en œuvre des interventions à haut impact, et enfin, la mobilisation des ressources pour la sécurité alimentaire et nutritionnelle. À ce stade-là, il y a beaucoup de progrès qui sont réalisés en matière de fortification dans la sous-région, des efforts conjugués de la CEDEAO et de l'UEMOA en même temps pour tout ce qui concerne la régulation et les mécanismes qui permettent au pays vraiment d'aller de l'avant. Il s'agit, entre autres, de la résolution adoptée par l'Assemblée des ministres pour avoir la fortification comme obligation au niveau de la sous-région pour ce qui concerne la farine et l'huile. Nous avons également le dialogue entre le partenariat public-privé qui est beaucoup encouragé dans la sous-région, l'établissement des alliances au niveau des alliances multisectorielles au niveau régional et national également, pour tout ce qui concerne donc la mise à échelle des fortifications au niveau de la sous-région. Actuellement, les progrès sont vraiment réalisés et on peut citer entre autres l'administration donc du fer acide folique dans les programmes de prestation des soins de santé primaire. Ça, c'est pour permettre au niveau prestation d'améliorer la prise en charge des femmes enceintes ainsi que des enfants dès la naissance. Nous avons également harmonisé la régulation sur les normes de régulation au niveau de toute la région ouest africaine. Nous avons des directives qui concernent l'assurance qualité et de contrôle pour la conformité, donc ici de ce qui concerne la mise à grande échelle de la fortification alimentaire, etc., pour ne citer que cela. Nous pouvons aujourd'hui dire que des progrès aussi de façon plus spécifique concernent ici 64% des pays qui sont en train de mettre en œuvre des programmes universels d'accès de fortification. Et 80% des pays ont déjà établi l'iodation donc du sel, le programme d'iodation du sel, et avec la farine ainsi que l'administration du fer acide folique. Également, l'huile végétale est fortifiée associée avec la vitamine A dans 87% des pays. Il y a également la fortification du maïs, où on observe 3 pays, la Côte d'Ivoire, le Nigeria et récemment le Togo, qui a commencé, même en l'absence donc de législation. Bien entendu, la plupart des pays, comme je l'ai dit, ont déjà mis en place la réglementation qu'il faut pour ça. Alors, les priorités pour les 2-3 prochaines années de l'Organisation ouest-africaine de la santé, il y a un point de levier qui est, en tout cas, la redynamisation de des alliances nationales de fortification alimentaire pour arriver à créer une alliance régionale afin vraiment de dynamiser ce processus. Actuellement, nous sommes en train d'initier donc une analyse situationnelle en la matière. C'est aussi l'établissement d'un observatoire régional sur la nutrition qui va donc essayer d'endiguer un peu la question criarde du manque de données. Et nous allons nous entendre sur des indicateurs traceurs clés de nutrition afin de pouvoir suivre la tendance au niveau régional. L'OAS, comme vous le savez, a la plateforme de forum de nutrition qui est donc l'occasion de faire le point sur la mise en œuvre des recommandations, mais aussi de faire des résolutions et des appels à action sur les questions spécifiques liées à la nutrition. Nous évoluons également sur tout ce qui est renforcement de la régulation, la promotion des interventions sensibles de nutrition et également pour tout ce qui concerne la formation tertiaire au niveau de la nutrition. En conclusion, je dirais que nous voulons lancer ici qu'il faut un appel, en tout cas, à une volonté et un engagement politique très fort qui doit placer ici la priorité chez les adolescentes et les femmes en âge de procréer en vue d'accroître notre agenda de développement. Et il nous faut renforcer donc des stratégies intégrées qui soient multifactorielles et multisectorielles. Nous voyons que la plupart des pays, bien que la plupart des pays disposent d'une législation sur la fortification obligatoire, la fortification est un processus évolutif et dynamique qui nécessite une réévaluation continue fondée sur des preuves, des performances et des priorités, ainsi que qui doivent viser l'impact de ces interventions sur les conditions de vie de nos populations. Je vous remercie pour votre aimable attention.
Thank you very much, Dr. Namudu, for your comprehensive presentation, which covered the situation in West Africa, pointed out to some of the challenges that we are facing. And this is bridging nicely between your presentation and the next one, which is going to be given by Dr. Namukolo Kobi. Dr. Namukolo Kobi is a research coordinator at the IAR program on agriculture and nutrition. Namukolo Kobi is currently working in the country coordination and engagement unit of that organization on agriculture for nutrition and health, led by the International Food Policy Research Institute. Her research focused on improving the link between agriculture and improved nutrition and health outcome. She connects research data to national and African continental process, promoting the use of evidence to inform policy decision at the national, subnational, and continental level in Africa, working closely with national government and the African Union. In addition to her continental commitment, she is the national coordinator for the A4NH in Ethiopia. Dr. Namukolo Kobi is going to talk to us about why is it that anemia is so difficult to address, pointing therefore to the challenges, and more specifically, how the food system can be leveraged to address anemia in the continent. Dr. Namukolo, welcome. The floor is yours.
Thank you very much. I'm struggling to put my slides on presentation mode, so I hope this is okay if I continue presenting like this in the interest of time. Can you hear me?
I think it should be fine. Yes.
Okay, thank you very much. So I will focus on anemia, but touch on perhaps the issue of can food systems, a food systems perspective actually help us? It looks like my screen is frozen. I'm going to stop sharing.
Dr. Kovic, I can run.
Can you share from that side, please? I'm struggling. It's not working.
No problem.
Are you sharing?
Yes, a second, please.
Please advise.
Sorry, a second, please.
Maybe I can speak to.
Can you try to reshare once again and see if it's gonna work?
I am not the one who's sharing now, so I think the challenge is, it seems the settings doesn't really allow me to do much.
Please, can you
I can
confirm
see
you
the
see
slides.
presentation?
Yes, I can see the slides now. Thank you very much. So you will help me from that side. Sorry about that.
Please go ahead, Dr. Pradeep.
So that I'm going to focus on anemia, but
we have an echo. I don't know if those who are not speaking can mute, please.
So my presentation, I'm focusing on anemia, which is highly prevalent, as you have seen already from others, and that look at why is progress actually being so difficult, and perhaps can the food system perspective assist us. We need to pay attention to the fact that anemia in terms of iron deficiency anemia does not normally exist alone and comes with multiple other micronutrient deficiencies because of the lack of diversity in our diets. And therefore, we need to look to food systems as well to look at how we can incorporate that element into the toolbox that we then use. Next slide. The slide is not moving. Okay, thank you. So one of the first thing I want to refer to is the fact that within the UN Food Systems Summit process that is ongoing now, which many African countries in West Africa are actually engaged in, the staple fortification and biofortification have been framed as complementary interventions. And we need to look at this also as an opportunity in looking at ensuring we have a holistic approach to addressing anemia. So your industrial fortification that has been talked about already, we are adding micronutrients during processing as we do in maize and wheat flour. And then there is biofortification, which Her Excellency Ambassador Sako spoke so well about in terms of the fact that there's a lot that's been done on the African continent. And here we are increasing the levels of micronutrients like vitamin A, iron and zinc in selected staple crops. And on this slide, you can see vitamin A cassava as an example. But it comes with a package with fortification. And I'm looking at one of the labels on the right next to the deworming sign has to do with fortification in South Africa, where they have fortified with 11 micronutrients. And I'll come back to this a bit later. And then you also need to think in terms of the underlying background within which this fortification will be done, which is going to require interventions on deworming, on water, sanitation and hygiene, food safety, and other nutrient-dense foods, without which we don't have a full complement of dietary perspectives that can actually help on anemia. Next slide. So this is just to show what the map on biofortification looks like in Africa, that there has been an extensive effort and interest to bring on board biofortification. Scaling up is a different story, but at least we do see quite strong political will to want to do biofortification. Next slide. And in terms of biofortification, specifically referring to anemia, we do have varieties that have been released. For example, we have millets that have got both iron and zinc biofortified in them. We also have iron beans in some African countries that have been released. But we also don't forget about things like vitamin A sweet potato, or the cassava that I mentioned about, or maize, because of the complementarity of dealing with anemia when you have both iron and vitamin A, which are important. So from a food systems perspective, looking at the complementarities between biofortification and the industrial fortification, which is the focus of this meeting, is important. And as we deliberate during the conference, we need to keep that in mind, that the developments on these parallel routes would be complementary and helpful, but only if we think through how we are going to actually work with those complementarities. Next slide. The other thing is to keep the context in focus. And here we need to also think in terms of our traditional and indigenous foods that we might actually look down on, but which form the broader potential for increasing our diet diversity in our different country contexts. I want to refer here to a recent study in 2020 by Fisa et al. In South Africa, where they found nutrient density and not so much the cost of diet was associated with anemia and iron deficiency in school-age children. There's a caveat to this, in that, as I said earlier, South Africa has fortified maize meal and flour, the two main staples with 11 micronutrients, including iron and vitamin A, and with very high coverage rates. So essentially, this study needs to be interpreted against that background of the fact that the background diet already is very highly fortified with respect to iron, but that in that context, diet diversity is still important. And so as we speak of fortification, which is extremely important, we must not lose sight of the rest of the diet that we must also pay attention to. And indeed, both industrial fortification and biofortification are looking at providing more nutrient-dense food basket without much change to consumption patterns. Next slide. Here, I want to draw attention again to the UN Food Systems Summit process. And here it is a cluster of solutions that has been put forward that combines dealing with women's nutrition, focusing in particular on anemia, economic empowerment, and leadership. And the cluster is on accelerating action for women's nutrition, empowerment, and leadership. Here is looking at the work that the Alliance for Anemia Actions is doing and complementing that with work on women's enterprise hubs that specifically focus on traditional foods that are nutrient dense, so that there is a combination between how we address anemia, the enterprise hubs involving women selling foods that are actually nutrient dense, and then leadership to bring on board the global systems 50-50 agenda, where we are looking at women's leadership as an entry point to ensure that issues that address things like anemia, which predominantly affects women, will also, and children by the way, will also include their leadership in shedding light on what would be most effective within the context that they are operating, so that their views become part of how we intervene. Next slide. And then, so I want to finish off with my key messages, which are that fortification is important and that it must be positioned within the broader food systems context to address issues around diets, and that this would be a holistic approach which would address different underlying factors, and then that communities face multiple micronutrient deficiencies, but that anemia, when addressed, should be leveraged also as an entry point to address other nutrition deficiencies, which can be addressed within that broader food systems perspective, increasing diets while also fortifying, but looking for complementarities so that our ability to address anemia and other nutrients actually can be accelerated. Thank you, and over to you, back Chair.
Thank you very much, Dr. Namokolo, for your presentation, which is really laying out clearly how the food system can be leveraged to address anemia, but not only anemia, but also the other micronutrient deficiencies. Let's now hear from the next panelist, who is Dr. Saskia Ozendrap. Dr. Saskia Ozendrap is the director of Micronutrient Forum based in the USA. She is a well-renowned nutrition scholar with over 25 years of experience, and she brings her expertise in child development, micronutrient, and enrichment. She has proven track record on in public health and private sector successful international research collaboration, program design, impact evaluation, and innovation project launches. Currently, she is the executive director of the Micronutrient Forum, leading project on the lack of data on micronutrients, women's nutrition, and co-organized the Standing Together for Nutrition Consortium analyzing the impact of COVID pandemic on nutrition. Originally from the Netherlands, Dr. Saskia has a PhD in nutrition from Wageningen University, and her research was also associated. She was also associate professor of micronutrient and international health books. She's going to talk to us about the challenges on addressing anemia and what are the gaps that we need to fill to successfully reduce anemia among children and women. Dr. Saskia, the floor is yours.
Yes, thank you very much, Dr. Nanama, and good afternoon or good morning or good evening, wherever you are, and your excellencies and respective organizers of this consultation, and ladies and gentlemen. I'm very pleased to be present here at the consultation. I would like to applaud also the organizers for organizing this important consultation, recognizing the importance of the burden of micronutrient malnutrition, but also the good news that we do have cost-effective solutions that, as was indicated before, may not be the silver bullets, but may be able to produce important and to result in important progress if we are able to effectively scale it up. So in my presentation, I'm gonna build on the presentations of the other speakers in this session and go more in depth into what are the specific challenges that we've faced causing that we didn't see a reduction in the prevalence of anemia, what's missing, and what could be potential solutions. Also going to a bit more in depth into this proposed Alliance for Anemia Action that Dr. Namokolo-Kovic already alluded to. Can I have the next slide, please? So as we've heard from both Dr. Onyango and from Dr. Kita, anemia among women of reproductive age remains an important public health problem, particularly in Africa, where we see staggering prevalences of 50% of almost 50% of women of reproductive age, but also globally, where almost 40% of the young children and 1/3 of all women suffer from anemia. And this is despite the fact that a 50% reduction in anemia globally in women by 2025 has been included as one of the SDG 2 indicators recently. And it's in fact the only SDG target that's related to micronutrient malnutrition and to women's nutrition, as also Dr. Onyango already explained. So anemia actually reveals many underlying limitations in women's health, in their environment and in their diets. And we know that there are risks of immediate and lifelong consequences for health and survival due to anemia. Can I have the next slide? We've heard about the fact that anemia impairs health and economic productivity of women, and consequently also of the next generation, as there is a strong association between the prevalence of anemia among pregnant women and child mortality and adverse birth outcomes. We also have heard that anemia is actually an equity issue. Women bear the greater burden and have the biggest potential also to benefit from programs that address anemia. So interventions that tackle women empowerment, therefore, needs to be at the core of integrated programs addressing anemia. Next slide, please. Okay. So we've seen last year that the COVID-19 pandemic has clearly added to the issue. We know that the pandemic has disrupted food systems, has disrupted health systems, and has caused an economic crisis. It has made it more difficult for populations to access and afford nutritious foods that are rich in micronutrients, including iron. And it's pushing more children to become wasted and or stunted, and potentially can cause an additional of 258 child deaths caused by malnutrition per day. And projections of the Standing Together for Nutrition Consortium indicated that the COVID crisis could just results into an additional 13.6 million children that would become wasted by 2022, and in an additional 4.8 million maternal anemia cases by 2022. So COVID has further exacerbated the need to really take micronutrient malnutrition serious now, and to really think about integrated approaches to solve the problem or of micronutrient deficiencies and anemia in particular. Next slide. Now we've heard about potential reasons for the lack of progress, and I think an important reason that Dr. Onyango alluded on is the lack of reliable population-based representative data on the scope of the issue of micronutrient malnutrition, and on the progress and the quality and compliance of micronutrient programs, and in particular also of large-scale food fortification programs. In addition, as was indicated as well, anemia is an issue because it is a very complex multi-causal phenomenon that can be caused by iron deficiency or by lack of adequate diets. But nutritional anemia is not the only not the only form of anemia that we have. We also know that malaria and other infectious diseases are an important cause for anemia. And therefore, we really need to take the context into account when we design effective intervention packages. Recent research has shown that the proportion of anemia that is amenable to iron interventions is highly variable by its context, such that we see that increasing iron intakes can reduce up to 70% of anemia cases in contexts where the infection burden is low. But in contexts where the infection burden is high, we can only address maybe 35% of all anemia cases with iron interventions. And therefore, a set of other integrated packages is required that must be responsive to the causes of anemia and to the etiology of anemia in a specific context. We also know that there are issues with diagnostics. Existing anemia data may therefore not be detecting those truly at risk. Again, a study in Uttar Pradesh in India that was recently launched showed that the prevalence of anemia differs whether you look at measurements of hemoglobin using capillary blood, which is the finger prick, or venous blood. And in this particular study that was carried out among women in Uttar Pradesh, it was shown that when hemoglobin was measured by means of a capillary blood, the prevalence of anemia was estimated to be 59%. However, when hemoglobin assessments was used by using venous blood samples, this prevalence in the same sample of women was only 35%, indicating that measurements that rely on capillary blood may actually be overestimating the issue of anemia and may result in diverting of resources from those who truly need the interventions and undermining confidence in interventions. Next slide, please. So, as Namukolo was already alluding to in the preparations for the UN Food System Summit, several game-changing solutions have been developed and have been combined in cluster solutions. And the Alliance for Anemia Action was one of those game-changing solutions originally proposed by stakeholders that include the World Health Organization, the Gates Foundation, USAID, GAIN, and the Micronutrient Forum, but quickly also gaining momentum and now have stakeholders from both global research and NGOs and UN organizations, as well as from local and country organizations, including also a huge interest from several African countries. The Alliance for Anemia Action is striving to address anemia in a holistic way that leverages the knowledge, tools, and capacities of multiple sectors, looking at context specific based on a thorough understanding of the etiology of anemia, packages of interventions that go across food systems. So yes, it will need to include food fortification and biofortification interventions to improve the quality of the diet, combined with health system interventions that includes supplements, micronutrient supplements, for instance, provided to pregnant women that have very high needs through antenatal care programs, but also health interventions that address infectious diseases or malaria control. And with environment interventions and wash interventions that can also tackle the other underlying causes of anemia, combined with interventions to improve women empowerment. All this embedded in a global action plan on anemia that will need to be developed, that includes an integrated research agenda addressing the remaining issues that there are in the diagnostic assessment of anemia, and in remaining implementation science questions related to effective delivery channels of these interventions, making these interventions more effective. So this alliance has now been presented as part of this cluster and coalition on gender and women leadership, and it will be developed further beyond the Food System Summit to the Nutrition for Growth Summit. And although initially developed by and initiated by global partners, the alliance will be country-led. So country stakeholders will be joining a group of global stakeholders, and together we'll move the alliance forward. And with this, I would like to end the presentation. If you want to have more information on the Anemia Alliance, the organizers can share the contact details in the chat. And I would like to thank you very much for your time and your attention. Thank you.
Thank you very much, Saskia. We have heard from the four panelists who have talked about the magnitude of the problem of anemia globally, in Africa, narrowing down to West Africa, pointing to the lack of progress that we see and the challenge for most of the countries in the region to meet the global level targets. We've also heard what are potential solutions, what are ways that we can use to try to overcome some of the challenges that are on our way in trying to reduce anemia, mainly through fortification, leveraging on the food system, and also trying to have a holistic approach. Now, if the organizers allow, I know that we are running behind time, and if we can devote like 10 minutes for question and answers. I can see from in the Q&A box that there are a lot of questions. I understand that we might not be able to provide answers to each of these questions now, but definitely there will be answers to each and every single question that has been raised. So maybe let's open the floor for people who want to ask questions live. Otherwise, we can also select questions from the Q&A box.
Mr. Dr. Nanama, I'll give you 5 minutes for that.
Oh, 5 minutes. Okay, so that gives us just the time for one, maximum 2 questions. Let me just go through the chat box and see some of the questions. Unless there are suggestions, I would just pick randomly some of them. There is a question from Stephen. The question is, j'aimerais savoir s'il existe un protocole de fortification des aliments. Si oui, il est pour l'Afrique entière ou pour chaque pays? Et des questions pour la discussion, quelles sont les mesures essentielles pour lutter contre la malnutrition sous toutes ses formes, en particulier les carences en micronutriments en Afrique de l'Ouest? Je crois savoir que cette question, même si elle n'a pas été spécifiée à qui elle s'adresse, pourrait être adressée par Dr. Namoudou. Dr. Namoudou?
Oui. Pouvez-vous répéter la question, s'il vous plaît?
En fait, c'est une question à 2 sous-questions. La première, c'est est-ce qu'il existe un protocole de fortification des aliments? Et si oui, est-ce qu'elle est pour l'Afrique entière ou elle est pour chaque pays? Et la deuxième, c'est quelles sont les mesures essentielles pour lutter contre la malnutrition sous toutes ses formes, en particulier les carences en micronutriments en Afrique de l'Ouest?
OK, merci beaucoup. Merci pour la question. Comme on l'a dit, les questions nutritionnelles sont très complexes, mais nous avons dans notre sous-région, l'UEMOA, comme vous le savez, qui couvre 8 pays, et la CEDEAO qui couvre 15 pays. Et les 8 pays sont dans les 15 pays, bien évidemment. Et donc, les 2 organisations sous-régionales sont en accord déjà pour mettre en place des mécanismes au niveau régional pour ce qui concerne la régulation et aussi pour ce qui concerne les directives en matière de fortification. Et nous savons qu'actuellement, nous faisons le suivi, évaluation des pays pour voir le niveau d'application de ces mesures-là. Il y a beaucoup de progrès, bien sûr, qui sont réalisés. Et ça, c'est la partition régionale que nous pensons qui est toujours très important pour pouvoir diriger les pays et avoir donc la stimulation nécessaire afin d'aller de l'avant dans ce domaine. Évidemment, pour ce qui concerne la lutte contre les micronutriments, nous savons que la fortification alimentaire est une des stratégies les plus importantes. Et comme ça a été dit tout à l'heure, il y a aussi d'autres facteurs qui causent cela. Il y a d'autres maladies, les maladies infectieuses, les maladies parasitaires comme le paludisme, les infections diarrhéiques et autres qui peuvent aussi contribuer donc à l'avènement de cette anémie chez le jeune enfant, l'adolescente aussi, la question de gestion des menstrues et aussi la femme enceinte, compte tenu de son état physiologique, et tout ce qu'il faut pour lutter au niveau des centres de prestation de soins pour les activités de routine, mais aussi pour des activités d'envergure nationale qui concernent la fortification alimentaire. Toutes ces mesures, les pays sont en train de les mettre en œuvre, certes à des niveaux variés, mais les progrès sont certes, comme on a dit, lents, mais quand même nous allons de l'avant et il y a un suivi qui est là régulièrement pour les rencontres sous-régionales, amener les pays à faire le point et à partager les meilleures pratiques afin d'accélérer donc la mise en œuvre au niveau des pays. Voilà ce que je peux dire. Les stratégies existent au niveau national et au niveau sous-régional. Et nous amenons donc, ça a été dit tout à l'heure, la question de financement qui est très important. Il faudrait qu'on ait le financement domestique afin de réduire la dépendance de l'aide extérieure. Et donc aussi, il faudrait qu'on ait des politiques qui puissent s'aligner cela, donc un engagement de très haut niveau afin que la nutrition demeure comme une priorité pour le développement de nos pays. Voilà ce que je peux dire brièvement sur cette question. Merci.
Merci, Dr Namoudou. Peut-être une question importante de mon point de vue, très rapide, parce qu'elle a été couverte par toutes les présentations. And maybe Saskia will ask you to address this question. It's a question to all the speakers. What the issue of data, lack of data has been mentioned. And the question is, what are some concrete action we can do in Africa to address this?
I guess that's a question to me, Dr. Nanama.
The question is for all the speakers, but I'm trying to see if you could address it.
Yes, thank you for raising this question and raising this issue. I think for a public health problem that is so critical, it's really there's really high need to address this issue of lack of data or the data gap in micronutrients. It's been one of the main conclusions of the Lancet series on child and maternal undernutrition that was launched this year in March. And at the Micronutrient Forum, we are also now working with stakeholders and partners, both globally as well as regionally, to address this issue of lack of data with several approaches. So yes, we need to have more status data on micronutrients that need to be collected by representative population-based surveys. But we also know that these surveys are time-consuming, are costly, and also at the moment, of course, are very difficult to perform in the context of COVID. So we are also looking at alternative approaches by combining sources of data that are out there in the field, but that may not be available in the public domain or may not have been published, using smart technologies such as artificial intelligence and other technologies to get access to that data, using modeling tools that are out there, or nutrition modeling tools that are out there to find proxies for these data, and looking at other ways of and development of smarter devices and tools that can help us to have access to these data, including alternative proxies that have been developed, and validate these more clearly for use in context of in Africa. So to give an example, the Dietary Diversity Index for women has been developed and needs to be further validated towards does it really address micronutrient malnutrition and the functional consequences of micronutrient malnutrition. So these are efforts that are underway, again, you know, with an eye on the Nutrition for Growth Summit that will take place later this year, where a number of partners will join forces and come together and say, we really need to now step up efforts and address this issue of the gap in micronutrient data. So if you want to have more information or need more, please contact us at the Micronutrient Forum, and we can link you to the correct people. Thank you.
Thank you very much, Saskia. Maybe to add on this, that in this region, there is already an example, that of Nigeria, who has really invested a lot in a national micronutrient and food consumption survey. And I think these are the type of initiative that we need more and more to be able to get up-to-date information on.
Correct. Yes.
Given the time, I would not try to summarize. I would just, I believe there will be a summary of each session that will be shared. I would like to just thank all the panelists for a very articulated presentation. I would also like to thank the organizers for, once again, for associating UNICEF West and Central Africa Regional Office through my modest person to this event and giving me the opportunity to share such a high-level panel. Thank you very much, and I'll turn it back to the main moderator of the forum.
Thank you very much, Dr. Nanama, and thank all the speakers for this session. I think it was a very interactive session. We have a lot of questions in the question and answer box. Please, I invite the speakers to look at those questions and try to provide the answers. And also participants, because some of these questions are not specifically addressed to the speakers, but some of them could find the answers with the participants or all the attendees to this meeting. So please kindly check the question and answer box and provide either your comments or your input to the various questions that are in there. So thank you again to Dr. Namara and all the speakers of this session.